Hi everyone, welcome. We're just going to give it another minute or so for folks to join. Thank you all for being a little bit early. It's always exciting. If you have a moment, we're going to be using Mentimeter today, and we would just love for you to put a little pin on this location. You can use the link in the chat. You can go to menti.com and use the code 94014678. Or you can scan the QR code. So a couple different ways to put a pin. Already see some folks from California joining, so thank you so much. Um, yeah, we'll just give it a minute and let folks tell us where they're at. Great. We're filling in across the country. Thanks for the folks in Hawaii who are here. Well, this is earlier for you. Got some Alabama, Georgia folks. Got a couple of those on the line as well from our staff. Got Midwest, Texas, California, Washington. Amazing. I appreciate the little orange dot. That's creative thinking. And we know that that is a hallmark of medical respite care. So appreciate that. I'm going to go ahead and drop the Mentimeter link back in the chat again. For folks, again, you can use the code at the top of the screen, scan the QR code, or use the link in the chat to join. Just pop on here. We'll get started in just a minute. All right. I am going to go ahead and get us started. Great. All right. Thank you all so much for joining us today. My name is Lauren Berner Davis. I am the Director of Community Engagement and Impact at the National Healthcare for the Homeless Council. And I'm always excited to be in spaces with the NIMARC team. And yeah, we just love working together. So very excited to be in this space with you all today. I'm based in Nashville, Tennessee, and we are going to talk a little bit about one of my favorite topics, which is diving into how we can use data better and looking at medical respite outcomes and evaluation. We are going to be together for a while today. And so we're going to spend some time just doing a quick introduction to some key concepts so that we all know what we're talking about and are using kind of the same language. We'll talk a little bit about what type of data we're collecting, how we're going to collect that data, hear directly from folks who are doing this in medical respite spaces and hear from your peers, give you a little bit of a break, have some time to talk to each other. We'll talk about how we're going to use data, um, having more conversation with your peers, and hearing from folks, and then jumping into a presentation from the in-between before we wrap up today. We've got a really exciting group of speakers joining us. Again, I'm Lauren. I'm really excited to have my colleagues, Craig Mendoza, calling in from Augusta, Georgia, Joey Kenkel, also here in Nashville. And then we've got a couple community panels. So we're very excited for Keisha Shaw, Cassandra Alvarez, and Jamie Kimbrough. as well as Mariah Nunnally and Ashley Brand and Jillian Olmsted, sharing their experience with you all today. So really appreciate them and excited to hear what they're up to. As I mentioned, I'm just going to give a quick introduction to um, quality improvement and program evaluation and kind of lay the foundation for the rest of our time together. We really wanted to kind of lay this foundation in the context of the standards for medical respite care, which I'm sure many of you are familiar with, and really leaning into Standard 8, looking at this idea that medical respite care is driven by quality improvement. And we know that quality improvement is really this systematic and continuous set of actions that can lead to measurable improvement in the services that are provided in medical respite programs. And that clearly defined outcome measures and data collection protocols are really imperative to help programs tell your story about how your services are positively impacting your clients. We also know that this is one of the standards that is hardest for folks to meet. And so when we are looking at the self-evaluation for the standards, we know that about a third of programs say that the standard 8 is unmet, that formalized plans don't really exist yet, or that you're in the early stages. And that's totally understandable. Respite is an emerging field. We know that kind of this standardization of quality improvement and quality outcomes and evaluation measures is something that is really important, but often falls to the wayside when you're just trying to provide quality care to people. Measuring it is not the thing that's top of mind. Wanted to just highlight this idea that medical respite or in medical respite, we often are kind of thinking about program evaluation and quality improvement in the same conversation, and we're doing that here today as well. But that these are really separate practices that are complementary and they overlap, but they are distinct. And so when we're thinking about kind of this spectrum of how programs are using data or this cyclical nature of quality improvement and program evaluation, I encourage you to think about kind of where it makes sense for you to start in this process. And maybe you're starting with quality improvement and you're really just starting to jump in, think about what are the things we can do to move forward quickly and start improving our program. And then thinking about where evaluation falls after that and making sure that the changes that you're making in your quality improvement processes are actually doing the thing that you want them to do, and vice versa. Maybe you started with program evaluation and you've identified some areas for improvement, and then you can move into this quality improvement space. And so recognizing that this is kind of a cycle you're moving through, and it might look different each time you move through this, but that these processes really do tie together, but they are kind of separate in how we approach them. We are going to spend most of our time today talking specifically about quality improvement, but recognize that evaluation, again, is an important part of this kind of data life cycle that we see in our programs. So just to quickly touch on kind of the definitions that we're going to be using as a foundation for this, when we're thinking about evaluation, the CDC is defining this as a systematic method for collecting, analyzing, and utilizing data to examine the effectiveness and efficacy of our programs. And even this definition highlights that evaluation can be an important part and contribute to this continuous program improvement. We think evaluation is really important because it can help us monitor progress towards our goals. It can determine whether or not program components are actually doing what you're hoping that they're doing. It's going to let you make some comparisons across groups and subpopulations, and you might be able to segregate your data looking at high risk factors or adverse health outcomes. It can help you justify the need for funding, which we know is really important in this environment. It can help you find those opportunities for quality improvement and can ensure that resources are allocated effectively. When we think about quality improvement, the CMS definition really thinks of QI as a framework used to systematically improve care. Um, it highlights this process of standardizing processes and structures to achieve predictable results, and improve outcomes. And so this is kind of the understanding that we'll be using for today. There's several key domains of quality that were defined by the Agency for Healthcare Research and Quality, or AHRQ, or ARC, depending on how you frame that pronunciation. But the real key pieces of quality here are safe, making sure that our care is avoiding harm for the folks that we are intending to help, that care is effective, and that we are providing services that are based on scientific knowledge that can to those who actually can benefit from it, and for folks who are not likely to benefit from a service, we're not providing that. That our services are patient-centered, really making sure that we are responding to patient preferences and needs and values, that our services are timely, and that we're reducing harmful delays, um, that we are efficient, and that we are equitable and providing care that does not vary in quality across our patients. When we think about quality improvement, of course, we have to think about what quality measures are, and those are the tools that help us measure or quantify healthcare processes, outcomes, patient perceptions, really thinking about what are the things that we need to know to be able to provide high quality care, especially thinking about how we measure our ability to meet our quality goals for folks. And so those goals ideally align with some of those dimensions of quality. So making sure that things are patient-centered, equitable, safe, and things like that. But why does this feel so hard in the medical respite space? And it's not just medical respite, it's the healthcare for the homeless space in general, too. We know that resources are limited and that you're already having to be creative with the resources that you have. And so, again, putting together the infrastructure or time to do quality improvement and actually measure this sometimes doesn't rise to the top of your priorities. Completely understandable. There's a mismatch in metrics. And so the standard QI measures, if you're looking at kind of what healthcare broadly looks at, might not easily fit into what our population needs. We know that our folks have a more difficult time navigating some of the traditional services that would traditionally help achieve some of these quality improvement measures, or there's additional complications for folks. So recognizing that this is not a one-to-one with a lot of our quality measures. Um, we have multidisciplinary care, which is super effective and important for our population, but also recognize that that introduces challenges with how we track and chart the work that's happening, especially if we're using external partners and having these kind of multi-agency, multidisciplinary teams. Maybe somebody else is using a completely different tracking system than you, and how do you navigate that? We know that that's a difficulty. And then again, this idea of competing priorities. We know that there's a lot going on. You've got a lot of folks that you're working with and through and providing different care to patients. And we know that quality measures and quality improvement might not be the top of that list when you're really trying to provide patient care. And so all of that considered, it's really important to start with defining your scope, not trying to do anything too big from the front, on the front end. So being honest about what your capacity is around quality improvement and understanding what your goal is. Is your goal to improve the process at this point, or is it to look at these longer term outcomes? What's the intended utility of your quality improvement process? And who's the audience for results? Is this trying to think through how you're going to adjust care with clinical providers? Is this looking at how you make changes in policy at the organizational level? So understanding kind of what your goal is and what you have the ability to do now. And then defining your scope, some considerations and some questions to ask as you're thinking this through. What's the purpose of your quality improvement process? Who's going to use the results? How will they use those results? What do other stakeholders need to improve quality? What stage of development is the program or the intervention that you're looking at? How intensive is it? And what are the relevant resources and logistical considerations? Is Joey on yet? I know he was having some internet
Still
issues.
trying to connect.
Okay, perfect. Um, so moving into this idea of what we are going to collect. So data is used to determine outcomes consistently. And if we're trying to think through like what these different pieces are, you're collecting data at intake, you're collecting data um, at the bedside, you're having conversations with your partners, you are collecting information at discharge. So there's a lot of different places that data is collected across medical respite care, and also a variety of different types of data that you're collecting. Again, so going back to this idea of um, what is your goal? Thinking through kind of what pieces of information you're already collecting and how is that going to help you get to your goal? And that can be a place of what you're going to collect. Where you're going to collect is also really important. So recognizing that maybe the information you're getting at intake, maybe there's not trust built up yet. Maybe somebody's not willing to share all that information yet. And so potentially having those screenings at different points or collecting data at different points can be useful. Similarly, recognizing that folks have different relationships with different people. The person who's coming in to provide a service once a day versus once a week, that relationship is going to look different, and potentially be in a different place to collect accurate information. Similarly, depending on the screening tools you're using and things like that, there might be certifications needed or training needed to get that information. So recognizing kind of the pros and cons of what types of information you're collecting, how that's going to impact your ability to measure your goals, where you're collecting that information, and who's collecting that information as well. When we think about the specific outcomes tied to medical respite care, there's a couple of different categories we can look at. We can look at health outcomes, we can look at social outcomes, and we can look at program outcomes as well. If we're looking at specifically health outcomes, we can look at access to primary care or preventive care. It could even be connection to those services on the back end, assessments that you might be conducting, screenings. Are folks completing a care plan? Are they um, following through on the care plan? Was the care plan developed in the first place? And other specific outcomes depending on the types of services that you provide. So if you are, and the types of partnerships that you have. So if you are connected to a health center, maybe you are able to connect and look at some of those longer term health outcomes as well. So really thinking through, um, again, this all comes back to what are your goals and what are you hoping to achieve? So thinking about what those specific health outcomes look like for you, but starting with some of these, what are the healthcare assessments, screenings, and care plans that you're completing with folks. Social outcomes, thinking about those enabling services, social supports, care coordination, and where folks are discharged to. Enabling services and social supports, are folks working with case managers or their community health workers? Are we providing access to food, transportation, and things like that on the back end for folks? So thinking about kind of how we are connecting all of these different pieces that are what makes medical respite so unique as a care model, and also what we think makes it work for our population. So really thinking about how are we capturing the unique value that we are providing to folks. And then program outcomes, thinking about safety and patient engagement, compliance, programmatic, and staffing outcomes. Are we, on the patient engagement side, are we providing surveys around patient satisfaction? Are we engaging patients in programmatic design conversations? Are we getting their feedback on things? How are we measuring safety? How are we looking at our staffing models and tracking the types of services we're able to provide accordingly? So thinking kind of across these things, what are the measures that are going to get towards your goals? Now, I will give you a break from having to hear from me for a moment, and I want to hear from you. So I'm going to drop the Mentimeter link one more time, as I know a few folks have joined since. You can use this link in the chat, the QR code here, or enter the code 9401 4678 at menti.com. And I'm going to ask you a few questions. I also recognize that I've been talking very quickly, so please put questions, comments, thoughts in the chat. Would love to hear from all of you. Okay, first question. What are you collecting? What outcome measures or what data are you already collecting? If you have any difficulty with Mentimeter, you can also put that in the chat. Got folks capturing referrals, admissions, discharge, denial, claims data, where folks go after discharge, length of stay, some demographic information, services, hospital admissions, primary care, A1C, lots of things, yes. Length of stay, referral denials, self-reported health improvement, care plans, claims denial and approvals, lengths of stay, exit experience, love that, medication management, activity participation, behavioral health needs, housing navigation, referral sources, goal success, medical home. Got BMI, blood pressure, A1C, completion of care plans. Amazing. So you can see there's kind of a variety in what different folks are collecting, but there is some commonality across some of the different measures that we're seeing are most common. We're going to get a little aspirational. And what do you wish you collected? Knowing what would increase our funding. Referrals that are not coming in the standard process. Self-reported mental health changes. Where folks lived before. Do they want to get off the streets? Progress and resolution, primary condition, cost effectiveness, total cost of care, treatment program completion, budget. movement through other programs, compliance, authorization times, hospital readmissions, impact on ED visits and savings, housing, outcomes, decrease of high utilization. Yeah, so these kind of like larger questions of what is the large scale impact of medical respite on the healthcare system and the long-term outcomes for patients. Justice involvement, cost effectiveness, better quality data. Amazing. Just going to move us along real quick. How are you collecting? What tools are working for you? No good tools. Totally understandable. Completely fair. Jot forms, survey spreadsheets, Power BI, Excel, lots of pivot tables, uh, EMR, HMIS, manual entry, your table, daily logs, new data program and spreadsheets, EHR. Sometimes EHR is not user friendly. Google Sheets, sort of. HMIS, Excel. Guest satisfaction surveys. Wishing the reporting systems were more user friendly. Uh, Absolutely. I wish all data systems were more user friendly. Um, Analytics is time consuming. Yeah, data programs. Yeah, so a lot of variation in kind of the different data capabilities, which again, understandable depending on the types of partnerships and the level of infrastructure and types of providers that you have. All right. Is there anything you are struggling to collect? We've already touched on some of this in some of the other slides too. Differing requirements, hospital system impacts, health improvement, patient engagement. Comment in the chat, anything outside of their HMIS, whether patient completed respite admission goal. Hospital impact. Yeah. Yeah, going back to some of these things that we wish we were collecting, but they're difficult. It's not an easy system, especially for some of these things that require us to have information across other providers. Patient engagement. Not all data is entered consistently. That can absolutely be very frustrating. Um, Impact translated into fund to dollars. Global cap calculation, hospital follow-up for readmission, long-term outcomes. I would like my dream is that we're able to get to a place where we all have the capability to collect quality data easily, user-friendly, and in a way that can let us get to some of these long-term outcomes. And this is the group of people that's going to help us get there, even if it feels like we're still at stage one. So I'm very excited to be in this space with all of you. All right. How to collect data. Um, Based on everyone's responses, we know that everybody's got kind of different capabilities, but there's some tools and questions and ways that we can start this no matter what resources we have available to us. So starting with creating a plan and really thinking about how we're going to collect data and taking a moment to pause, understanding who is responsible for that data being collected. What are the outcomes? What do we want to know? What do we actually need to know to provide care? Um, what do we already have? What are the gaps? Knowing where we're actually capturing different forms of data. So knowing if something is captured in an Excel sheet, knowing if something is captured in HMIS, knowing that we have this form that someone completes, but it's not really connected to anything beyond that individual provider. So recognizing kind of where those different places that data is, and how are outcomes being produced, and kind of where we're looking for that impact to be. So some of the tools you've already mentioned, I think all of these as different opportunities um, for how you are collecting and storing this data. Some of you are using software and records for internal health and social services. So folks are recommending EHRs or case management software, also recognizing the challenges with some of those systems themselves. Some of the shared software with partners or local systems, maybe you are connected to your HMIS. Some communities may be able to link into a health information exchange or a community information exchange, depending on what exists. Required submissions to funders or regulatory bodies are a tool that you already have at your disposal. And then client surveys, client feedback, staff feedback and surveys as well. All different ways for thinking about how we are collecting data. And then really thinking about as you're creating your plan for data, who's going to be responsible for gathering client data? Who is going to be responsible for safe storage and making sure that we are protecting client data and uploading that into appropriate repositories? How are we managing the data? Who's making sure that it's cleaned or put in consistently, or that we have some training around data management and things like that. Who's actually going to be using this information? How are we starting to pull out some summaries or start to look at some of the analytics here? And then how are we communicating this information, and who is going to be responsible for communicating that back to the people that need to know or are part of this kind of quality improvement process in your program? And then going back again, where is this going to be stored? Making sure that we're thinking through all of the different resources we have available, and kind of how we are storing this information. So documenting in your plan if something is going to be included in an EHR or in HMIS, in a case management software, or noting that, this is not something that lives in an electronic system, but we have these files that are handwritten. Somebody is checking boxes. Where do those paper tools live? Are they going to be stored? How can we use them? And similarly with these reports that we're putting together for our funders, how are we storing them? How are we using them? Where does it live? And then thinking about other tools, we're going to be building off of our existing work. So if you're already doing client surveys, amazing. How can we start to adapt and adopt some of those? And if you're not already doing some of them, what does it look like to start implementing those program surveys? How are we going to start incorporating tools or components that were created by other programs? There's a wealth of information in this room. And so as folks are thinking about what the gaps are and what other folks are able to collect, how are we working together to identify tools that are going to be beneficial across programs? And how do we start adding those to our already existing program workflow? And then we highly recommend using validated measurements. There's a lot of tools that folks have already put together that you don't have to reinvent. and that we know will give you consistent information across your program. Some examples of some of these tools, again, I think Caitlin put in the chat, these slides will be posted, these links will be accessible to you so you can access any of these tools that might be helpful. But we have consumer assessment of healthcare providers and systems. It's a health literacy survey. We've got a care transitions measure, Barbara McGinnis House patient survey, Prepare, which is a social determinants of health screening tool that's been validated. And then the council and Kate, I'm going to shout out Caitlin and a lot of folks on the Respite Care Providers Network for their work on creating this validated self-assessment tool for the standards. So lots of existing other resources too. You might be using quality of life screening tools and things like that. So don't feel like you have to reinvent anything. Leverage the things that have already been shown to get you the information that you want. I am going to go ahead and hand it over to my colleague, Craig Mendoza.
Yeah, thank you so much, Lauren, for the great presentation. So we have a great panel discussion moving forward. And before we start, if we just maybe move down the line and have each panelist present themselves, maybe just name, where you work, and maybe how you use data collection on a daily basis or just in your regular work. So maybe we can start with Jamie.
Hi, everyone. Thanks, Craig. I'm Jamie Kimbrough. Can you guys hear me?
Yes.
Okay, cool. My microphone was acting up yesterday. I'm Jamie Kimbrough. I'm the housing manager at Mercy Care in Atlanta. I oversee our recuperative care program here, and I use data daily to track clients' progress in the program, so we can make real-time interventions, to work on reporting outcomes, and then just for like general kind of processes improvement. It's kind of the gist of how I use it every day.
Perfect.
That's it. Thank you.
And Cassandra?
Great. Greetings, everyone. My name is Cassandra Alvarez. I'm the program director of what we call Care Transitions, but it's recuperative care services for WellSpace Health. I also use data every day, really just to do a temperature check of our admissions, to understand what our discharges look like for the day, and also to monitor patient progress in our program as well.
Finally, Ms. Shaw.
Hi, everyone. I'm Kasha Shah, a nurse practitioner. I am the Vice President of Medical Services with Path Forward. So I oversee medical respite and regular nursing services to respite and shelter clients. And data for us means a lot of things. I think the biggest part for us is to see trends in especially like different disease processes, lengths of stay as they relate to comorbidities. And also a big part of our program is privately funded through grants and donors in the community. And so that the data that we collect is really important to prove to our donors that we are doing what we set out to do and show the quality of service that we're able to provide.
Perfect. Thank you so much. So moving forward, we do have some questions already prepared, but as Lauren said, if anything else comes up, you have further questions on, please put them in the chat. And if we have time, we'll try to address them as best we can. And for these questions for the panelists, feel free to just interject as you feel, and you guys can bounce off one another. So for the first question, how would you describe the current state of your program's data infrastructure and how you collect data?
Right, I'll go ahead and start. For WellSpace Health, our current state, I would say, is pretty messy. And the reason being is because we recently transitioned from one EHR system to another. So we're, obviously there's some data gaps between quarter 3 and quarter 4 for 2025. So right now it's just a little challenging to understand, what happened during that transition period and really just trying to clean up and catch up of 2025.
We at Mercy Care are also a little messy. So thank you, Cassandra, for saying that. Makes me feel a little bit better. We're undergoing kind of a revamp with our recuperative care program and looking to expand it this year. So trying to make sure that we have good processes in place for data collection and everything else. So I would say that our current data infrastructure is improving, but there's still definitely some more to be done with it.
Well, I'm just going to say the same thing. It is it is a little bit messy. There's always room for improvement. I think we're like going in between automated data collection and plain paper, logs collection. I think we have to really work within the constraints of manpower and time. And so, who's responsible for what? So there's always room for improvement, but we are definitely making headway in that direction.
Yeah.
Okay, perfect. And I'm curious, since each one mentioned messiness, is that something that's kind of just par for the course, or do you guys feel that there's a way to kind of get ahead of that messiness? Maybe like some advice or some tips for everyone else?
Truthfully, I think it's just trial and error, really just to understand, what's your starting ground and where you want to go and bridging the data in between. I think one of our biggest challenges is not only manpower. Obviously, it's been really challenging to keep sustaining staff, but going in between an EHR system and not having 100% confidence and trust in that system, and then utilizing like Excel sheets to also track as well too. So having these dual sources is beneficial because if there's a gap in one system, you can kind of piece it together. But it does create a burden up front. It's a challenge up front to constantly ensure, what you're duplicating on an Excel sheet gets appropriately put into an EHR system. As my VP, continues to chime in my ear, garbage in, garbage out with these types of things. So you really obviously want to always focus on your starting point of data collection and making sure you're constantly evaluating that process of how you're putting in data to make sure it's congruent with what you want to see coming out of your system or your collection mechanism.
I agree with Cassandra. I think also one thing for us, I think it is par for the course to kind of wade through all of the data messiness for sure. I think also one of the things that I'm hoping for in Atlanta is to be able to utilize our systems to their fullest capacity. So like receiving referrals from hospitals in EMR, so I don't have to go into a spreadsheet and manually track it because that's rife for errors. And like having data systems that can talk to each other, like our HMIS and our, hospital system, which have been conversations in Atlanta and I'm sure everywhere else too for ages and ages. But that's kind of my hope moving forward someday.
I think to kind of speak to what I'm hearing everyone else say is that one, manpower is the issue, right? So a lot of times, like in our case, I'm the one that's responsible for data entry or reporting. And what we have done is we have created Excel spreadsheets with drop boxes and all the different possible data that we need to capture. And I think the key thing is that if you're going to be the person that's going to be responsible for entering it, you got to build in the block of time that you're going to do that as it's happening, right? So maybe at the end of each week, you're going to just dedicate time to do that because that can get away from you so quickly. And then the next thing you know, you are like months out and all this data is just all over the place. And then when you're reporting you're scrambling to get all of that entered. So definitely allocate the time to do that because there's never enough time to just say, I'll do this at the end. No, I'll get to it when I get to it.
Yeah, doing what you can to get ahead of the messiness, basically.
Correct.
Yeah, exactly. Perfect.
And
Thank you guys so much.
I agree with Keisha as well too. If there are programs that are utilizing Excel, really getting the skills under you of how to do data validation, creating your own drop downs, it does make things a little bit easier and cleaner and less messy for sure.
Mm, perfect. Thank you guys so much. I think that gives a lot of helpful advice for people getting into data. Okay, so the next question is, how would you describe the current state of your program's data infrastructure? I guess we already kind of covered this, and how you collect data. If anything else stands out that we haven't covered already from that question.
Yeah, for well-spaced health, I think we're currently in a space, just as Jamie said, where we're restructuring as an organization overall. And how we, have built our recuperative care is we work in partnership with other pieces of our organization. So what satisfies our case management component within recuperative care is actually our ECM case managers sitting and living here in our facility. And so in the past, it's always been well, you collect your data over there and I do my thing over here. But now having conversations and with our organizational restructuring, it's forcing us to work together and to make sure that we're sharing the wealth and making sure we're all stepping up to provide the pieces that we intersect in. So just having strong communication skills and making sure that the stakeholders who, chop up and have pieces of your data are held responsible and accountable for giving that to you and supporting you along the way, I think is really important.
So I don't know if this may be true for others, but for me, like when I track the data, when I'm taking care of the clients, um, I initially handwrite it all in the log just because I'm going, and don't want to forget it. But it helps me retain in my mind, so I already know what the trends are as we're seeing more and more patients, right? If I was to just enter it into the computer, my brain doesn't work that way. It's seeing and writing it down. I know it's a duplicate, but um I think it's just finding a way that works for you to keep that data or the trends in your data in your mind as you're doing your day-to-day activities is important. So that way you can be ahead of or anticipating what may be occurring down the road. Like for a specific example, I mean, we have seen this trend in the aging senior adults experiencing homelessness gradually increase over the last 5 or 6 years. And now we are facing a crisis, right? But we knew that this was going to be happening, there's no way to escape this. And it felt like the community was just kicking the bucket down the road. Whereas my organization, we were already letting the leadership know at the county that, hey, this is what's happening on the ground. Let's plan creatively how we're going to approach this problem that's just keeps escalating. I hope that kind of made sense.
Yeah, absolutely. That was perfect. Thank you.
I think they covered everything that I was going to say. I don't have anything monumental to add to that.
No worries. That was perfect. And I think that leads us, it's easy to talk about the problems and things that don't work, but there was one question of what is working well. I don't know if you guys have anything like you guys kind of mentioned like collaboration with other departments. Do you guys have any examples of things that are working well that you guys can draw from?
Yeah, for sure, collaborating with different departments. I've seen the greatest progress when I started demonstrating and sharing data in our all staff meetings to get buy-in and for people to understand, like, this is the temperature check of our program. This is how you contribute to this data collection process. And so I found better integrity with our data when I did switch to exposing and sharing with our case management team, our clinical staff, so that they have a better understanding of what we're doing from a different lens. So that did greatly improve what's going into the system.
Mm.
Yeah, I think similar to that, like, I think our ability to even, it's like a blessing and a curse to access both HMIS and EMR and have access to all that data is working well, even though I would like for it to work even better. And then also, you know, our clinic partners are entering information in the same EMR that we're using for case notes. So having that ability to collaborate through that system is really helpful too.
I think in our case, like the spreadsheets that we have built, we're able to extract data that's specific to maybe a specific grant that has reporting data due. So it's really helpful to be able to just go in there and pull what you need to pull and give that to the development department so they can report off on it.
Perfect. Thank you guys. That's really helpful. Moving to the next question, kind of maybe a more technical question. Are there any methods, tools, or technologies that you guys use to collect and manage data? Or what would they be?
Currently, we're utilizing Power BI as one of our biggest tools that we use. We're fortunate to have an informatics team that supports us with extracting data and building those platforms through Power BI, building the sheets that have all the metrics of how to slice data and splice it in different ways. And I'm sure that that's not an advantage that everyone might have, is an actual team that can build those resources for you.
Yeah, I'll say we don't, unfortunately. I wish we did. And Cassandra, if you're offering Power BI lessons, I might connect with you on that. I think somebody said in the Mentimeter before, but lots of pivot tables is kind of what we're using to be able to do some data visualization. Hopefully that gets a little bit more interesting in the future.
Our primary tools is HMIS and then just the spreadsheets that we had someone who is very Excel savvy create for us. We're a very small organization, and so we don't really have an extensive budget to have someone that can do that for us, the data collection, data analysis. So I'm jealous, Cassandra. It would save so much time.
Yeah, there's still challenges with it. Like, even from the dashboards and that comment about pivot tables, I still have to pull it and pivot it. So it's nowhere near where I want it to be, which is an actual visualization. It's just a place where the data gets collected and you have various splicers, and then you still have to pull it down and splice it even more. So it's a great summary of what's happening, but it won't give you those details unless you do the manual work yet, where we are now in the stage of Power BI.
Perfect. And kind of mentioning in the past with cross collaboration, or even Keisha, when you mentioned taking data by hand, the next question is, how do you ensure data quality and accuracy and consistency across different staff members?
Yeah, a lot of validation, a lot of, just stringently sitting in a room, locking yourself away and looking through it. I think one of the most challenging parts of where we are now, because we did transition in the past, we used NextGen and now we have transitioned into Epic, is reestablishing the workflows to make sure you're getting what you need out of the system. It's been the biggest barrier.
Yeah, I think similar to that, definitely a lot of like head down and reviewing data consistently, providing like real-time feedback about, hey, this is something that I saw, recommendation to do this differently, that sort of thing, like staff development and TA. And then the other thing that we've done at Mercy Care is so within our social care department, which is multiple programs, not just recuperative care, we've had all the case managers start using one standard template. So they're all doing SOAP notes now in Epic. So that's a good way for us to kind of standardize it across the board too, and be able to provide like consistent feedback.
So we just implemented a quality control, like an official quality control program into our medical department. And so everyone knows what the minimum information and we need to collect for data reporting. And so they keep track of that throughout, day to day. And then each quarter they have to report those numbers off to me. And then on top of that, we have established that at the beginning, since the quality control is so new, there's going to be a monthly audit of the charts that random charts that the each individual is documenting in, just to make sure everyone is on top of it. And we have a standardized checklist, and then just provide real-time feedback so that they can improve going forward.
Okay. And just while we're on this section of tech tools, just to answer Zanika's question, what program are you guys using for case notes, if you have that information?
Similar to Jamie, we just have a template that's built into our EHR system.
Yeah, we use Epic for case notes as well.
Perfect. Hope that answered your question, Zanika. Okay, and then moving on to the next question. What types of questions or outcomes would be most meaningful to measure for your medical respite care program?
So in our case, I think it's really important to measure, like, where does the individual exit to? We strive to get them to exit directly into housing if possible, or at a minimum back to the shelter. Like, we never exit folks out to the street unless they decide to go on their own. The other thing is just overall quality stories of individuals, how they have progressed from, experiencing street homelessness to being able to transition into housing. Like, we even have a transition period when they go into housing where the medical team follows them along with the clinical social worker and their case manager to ensure that they have that seamless transition, since it's such a big adjustment for many of our folks. And what we have found is that because we're so funding, grant and donation dependent, those success stories hold a lot more weight than the numbers do. And so we always want to make sure that we capture those success stories along with the numerical data too. But they hold a lot of weight.
Yeah, we're setting up some new processes with our hospitals. So a lot of what I've been looking at, and a lot of what's been meaningful lately, is information on referrals. So like reasons for denials, turnaround time, any like recurring errors that I'm seeing in referrals that we can do follow-up hospital TA. And then I think longer term, one of the things that I really want to focus on with the program is working closely with our primary care providers to measure, from a healthcare perspective, improvement of whatever the condition was that they came in with while they were with us.
Yeah, and similar to what Jamie said, I know our hospital systems, it's important for us to give a lot of feedback, especially in regards to why we may be sending patients back. Oftentimes when we get the referral information, you can easily approve someone based off of the notes that you've received, but their disposition when they actually get here is completely different. And it's gotten so granular with some of our hospital systems where they're even asking for who was the case manager that you worked with on this referral. And it's like, that's a little bit stringent. That's a little difficult for us. I understand the importance, but I would like to see more, partnership around that. Like you should be able to figure that out if we can just provide you an MRN and, some dates around when that occurrence happened. I think another important question that should be posed during this time is when you're starting to create that plan around your data is what are some threshold metrics for you to institute action? And what would that action be? So let's say if, you have a capacity, your max capacity is 50 and you're going to hit that 30 or 25 threshold, like when should you do more or do something else? I think those triggers are really important to plan for because then you'll know what to do versus being stuck and then you're rushing to call the hospitals like, hey, give us more referrals, or hey, we need to quickly patch together a discharge plan because we're about to hit max capacity. So just really being able to monitor and understand what is your program's threshold and what are the actions you plan to do or can do when those things happen.
And you guys mentioned, like Keisha mentioned, success stories or referrals to hospitals. Do you guys have information on how these data points can help demonstrate the impact of your program? And maybe if you guys have any like success stories of how you've actually experienced that, like those success stories impacting your program?
I can start on that. I think one of the kind of biggest and easiest ways that we can show the impact of our program that's like easiest, I think, for hospitals and lay people to receive is folks moving from respite care into housing, right? So hospital to recuperative care to housing. So that's one that we've focused on. I think on a more like granular level, my focus has also been on demonstrating how we're, reducing hospitalization time when placement is the only barrier to discharge. Ideally in the future, how we're reducing recidivism to hospitals by getting patients linked with our care and us becoming their like primary healthcare provider. So things like that. But right now, the kind of like biggest and easiest and flashiest one is housing.
Okay. For us, definitely the exit plan is, the most, I guess, fidelity that you can prove to your stakeholders. Another piece that we are trying to kind of get off the ground is help surveying patients who are experiencing, maybe they're getting worse or not better, or maybe some symptomology, is to say, how can we vet and screen maybe this encounter requires an immediate care versus going directly to the ER. So taking a moment to pause with the patient while they're, experiencing that symptomology to say, where would you go if you were having this before? And would you be open to going somewhere else or trying something different? I think that really impacts our program because then we can show that, there's other interventions that, patients can utilize versus just going directly to the ER. And our program served that standpoint of outlining what those options are. But it's been a little tricky because, as you know, most of our patient population, they get very comfortable and, they know that ER, they know the staff at that ER, and that's kind of where that welcoming face is for them. But just, demonstrating that we've provided alternative areas or places for them to go rather than just cycling back through.
Fantastic. Thank you guys. Okay, moving on to the last section. What successes has your program had in building or strengthening data infrastructure?
One of the easiest ones we've been able to demonstrate is our patients being established in care. And I think the advantage is the fact that, for WellSpace Health, we are not just recuperative care, we also provide specialty and primary care services. So we're able to establish very quickly those who don't have established providers. We can do that in-house very seamlessly.
So I think a lot for us recently, I've been at Mercy Care for about 6 months, so this has all been kind of a building the plane as we fly it situation. But I think one of the things for us and that I've been focused on and we're starting to see some improvement with is just like being really intentional about the data that we're collecting. Why are we asking this question in intake if it's going to be asked again when our clinical provider sees them, and like really being again intentional about what data we're collecting, what's data for data's sake, what do we need for this specific purpose, that sort of thing.
I think in our case is we have really ramped up our mental wellness part of the recuperative care, where we have a peer specialist and a clinical social worker on staff that is able to address on site any concerns, and then also just building overall general wellness programs for our clients to participate in. And that has really helped strengthen our data in showing the community and obviously the donors and funders that we take into consideration the holistic approach to the client's wellness, not just the medical.
Okay, perfect. Thank you guys. And moving into, I think, something we covered a lot, and just for all those listening in, final takeaways, what lessons have you guys learned that could support other programs building their own data collection process?
I would just, start by saying the collaboration is really important. Again, making sure you strategize and plan for those threshold markers of, to trigger what you will do in certain situations. And making sure that everything that's being exported out of the system or out of however you're keeping the metrics is constantly being reviewed of how you're putting it in. Just to make sure everything is aligned and actually still working the way you anticipate it to work.
Yeah, I think going back to what I said before, I think a big lesson learned has just been intentionality with our data collection. Even down to like the pros and cons of entering data in both EMR and HMIS, that sort of thing. And really thinking through the pros and cons of all of that. Like we have access to coordinated entry now and are able to help people in the future hopefully get housing. Con, it's extra work and extra questions. But yeah, I think just really like having a critical mind about what you're collecting and why has been a big lesson learned.
I think like in our situation, it's also the collaboration piece, but I think for us, it's really important to collaborate with our development department that does all the grant writing and finding out what the grantors want collected and reported to them at the beginning of the grant versus towards the end of it. So that way you can update your data collection accordingly so that you're not scrambling at the end and trying to find that information. And also just building in the time to put that data in.
Perfect. That was fantastic. We have a couple minutes left. Is there anything that we haven't covered that you guys think would be helpful for other programs that maybe you would like them to know before they leave today's session? Any final wisdom from your programs? If not, that's totally okay. But I know they're all chomping at the bit for more information.
Yeah, it's kind of hard, when it's such a broad topic to talk specifics. But I, always invest in the power of collaboration. So I'm welcome to drop my email in the chat if anyone would like to set up a virtual coffee date to talk through it, or I can share some slides of what we've presented to the hospital systems so that you have maybe a framework or a structure. I'm more than happy to offer that.
Yeah, same. I don't know that I have anything extra to add, but also happy if people want to reach out and ask questions.
Same.
Perfect. That covers our panel. Thank you guys so much. That was an incredible session. You guys really covered a lot of information. Really appreciate your willingness to be here and speak, and especially now willingness to, meet with people outside of this panel. So thank you guys for participating. Um, Thank you everyone for listening to the panel. We're about to go on break, but before we do, Lauren, there we go. Before you guys go on break, if you're able to put in your choice for which breakout group you would like to be a part of, that way we can organize the breakout rooms during the break. And then once you submit your answers, we will be coming back at 2:25 or 25 after, so whatever time that is for you. So in 15 minutes, we'll be back. Thank you guys.
Well, as we keep going, please keep dropping questions, comments, musings into the chat. Love to tap into the expertise and the innovation in this space. I am going to share my screen again. And we're going to talk a little bit about how to use data effectively. I am sure there are folks in here who have some really incredible solutions. So again, drop those in. Part of using data effectively is actually parsing and analyzing that data effectively. I don't think you all signed up for a math class, so we're not going to spend a ton of time here, and you really don't need to be a statistician to be able to pull data effectively and make it what you need it to be. But we do want to just provide a few helpful tools for what analysis might look like for you. It's important to start by thinking about the types of measures that you're interested in. If it's an outcome measure, so really thinking about that longer term intended goal, whether that's rates of improvement on a condition or discharge measures overall, making an impact on cost or service utilization. Kind of those are those outcome measures and can be in varying lengths of time. Your process measures are going to be the way that you measure the implementation of your work. And so are you doing trainings with your staff? The number of times that you're offering medication reconciliation, the number of screenings that you're completing, and things like that. And then balancing measures, which I think are maybe the piece that is talked about a little bit less in some of this space. So highly recommend this IHI toolkit up here if you want to dive a little bit deeper into the definition of these measures and what they look like. But balancing measures are also kind of referred to as like side effect measures. And so thinking about the unintended consequences or impacts of some of the changes that you're making or some of the programs that you're implementing. So if you prioritized one goal or really implemented a robust quality improvement project to address a specific need that you're seeing, are there things that were deprioritized as a result? And were there any negative outcomes there? Were there any outcomes or impacts to staff well-being based on this? So what are kind of those external pieces that might be impacted by the improvement projects that you're working on? And then on the measurement side itself, thinking about plotting your data over time, really just kind of creating some of these trends, looking at your trend lines, keeping an eye on how things are shifting, is a really great place to start. It's really important to see if things are improving, if things are declining. We can see, are we seeing higher rates of positive screenings for depression, or are we seeing more improvements on anxiety measures, or whatever that looks like for your program, but just kind of keeping an eye over time on how that's looking so that we can start to identify areas for future improvement, and celebrate when we're seeing things moving in the right direction. Utility versus perfection. Cassandra, I really appreciated the whole idea of garbage in, garbage out, and data cleaning and making sure that we are capturing information well and making sure that we are, doing our due diligence with how we are collecting and analyzing that information, and recognizing that we're all starting from somewhere. And some data is better than no data. And so starting with what you have, if it's useful for you, wonderful. If it's not useful, that's a separate conversation, and we can talk a little bit more offline about how to make your data more useful, and thinking about, what does staff training look like? How do you build out forms in your EHR, like we heard about in our community panel earlier? But if the data that you have is useful, use it. And don't worry too much about having perfect data. That can be its own quality improvement project as you go. You can also use sampling. So using a sample of your patient data. So say, there are gaps in your data collection, doing a random sample to see what some of those trends, what some of those areas for improvement might be, how well you're reaching the goal, rather than necessarily needing to use it for everyone. Again, kind of going back to this utility versus perfection piece, but also not getting bogged down by too much information at once. And you can kind of start with this smaller section here. Another helpful tool as you're thinking about using your data and creating some of these quality measures, is really thinking about how you're defining your goals. You've probably heard SMART goals, probably heard of SMARTY goals, but we really just want to make sure that as we're thinking about the goals for the medical respite program, and how we're going to get to a place where we're being able to document our impact, and the broader impact and programmatic impact, making sure that as we're defining our goals, that they are strategic, they're clear, we're focusing on the details. They're things that we can actually track over time, so they're measurable, something we can actually attain. This is probably one of the harder pieces. I know so many of us want to reach for that pie in the sky, and the pie in the sky is an excellent vision. But when we're defining our goals for the purposes of our quality improvement projects, we want to make sure that we're actually looking for something attainable so that we don't get burnt out along the process. We want our goals to be relevant and meaningful, that it's aligning with those visions and those broader ideas too. We want to give it a time frame so that it's not seemingly endless. We can always add on another layer on the next round. Want them to be inclusive. As we're defining our goals, are there ways that we can bring in our patients, our clients? Are there ways we can make sure that we're including staffing from all levels, and not just making these decisions kind of at the top, but how we're incorporating our community and sharing power. And then making sure that our goals are equitable and that we're centering fairness and justice in how we are thinking about how we are achieving our goals and how we're going to get there. The next piece here is a PDSA cycle, and I know Caitlin talked about these in a past session. I wanted to bring them back because I think they're really helpful, and are kind of the cornerstone of a lot of quality improvement and evaluation work. PDSA or Plan, Do, Study, Act really allow for early implementation. You don't have to have it all figured out. You just make one quick change and you see how it goes. So you identify an issue, adapt the process as necessary. You test a single step within a tool or a process or your program so that you can focus on those specific areas for improvement. They're typically pretty quick and are just a small sample so that we can start to make these changes actually happen and that we don't kind of over plan, but we can actually move forward. And then at the kind of as we round this cycle, we pause and we ask again, like, what are we trying to accomplish? How will we know that this change is an improvement? And what changes will make that can we make that will result in improvement? Um, and as you see this study piece, you can start to fill in those pieces of, did this actually make the change that we're looking at? And if yes, great. How can we make it even more impactful? If no, okay, well, let's try something else and do this cycle again. Um, any effective program or process that we are doing in quality improvement is going to involve many, many rounds of this PDSA cycle. So again, progress, not perfection, is our goal here. The big thing we wanted to spend a little bit of time on now that isn't often part of a quality improvement or a program evaluation conversation is how are we actually communicating our outcomes? We don't want anything we find through these processes to die within a team, or not make it out of this conversation. There's a lot of different people that need to know what you found. It needs to be the folks on the ground that are going to be doing the work. You might want to think about how you're communicating it back to participants in your program, especially if it's going to impact changes in how they're receiving care or how they move through the medical respite program. It might be important, again, to communicate back to your funders, or it could be that, a partner or a leader within your organization really needs to be on the receiving end of this information. So thinking about how we're going to do that effectively, again, really knowing who your audience is, why you're sharing the results with them. And that's going to inform kind of what your product actually is and how you disseminate it and make sure that it gets out to the people that need this information. This is especially true if you're moving into sort of the programmatic evaluation, but is still true even for internal quality improvement work. As you're thinking about different types of dissemination, there's so many different ways this can look. You might have summary reports or one-pagers. It could be an email you send out. It can be a presentation you make at a staff meeting or a board meeting. Maybe it's something where you put together a newsletter or a press release, especially if it's something that you want funders and things to know about. Success stories, something we heard earlier too. The power of storytelling in data dissemination and how we talk about our impact is really important. And then dashboards. We've talked a little bit about using Power BI earlier or pivot tables. There's a lot of different tools we can use for dashboarding. And we'll dive into some examples of that in a moment as well. We are huge fans of mixed methods in our evaluation, in our quality improvement. It's not just hard numbers, it's also stories. It's making sure that we are communicating the number of folks that have moved into housing and what that's meant for people. It's making sure that we are quantifying the number of completed care plans and talking about how that has impacted someone's self-efficacy. As we're telling that data story, we want to make sure that it's accessible and understandable for the different audiences that we're working with, that we're thinking about the impact of demographic data, going back to the equity piece, and that we're thinking through the different ways that we can visualize that information. Want to share a couple of quick examples of what this has looked like in some different programs. This is an example where you can look at the current occupancy rates and the current number of patients and the current number of beds. This is a huge program, so it's probably unlikely that you're going to be looking at an occupancy rate for 1,000 beds, but what does it look like for 50 or 10? What's your patient turnover rate? And this dashboard includes patient satisfaction, so those satisfaction surveys that you're doing. This is something that is obviously created in some sort of dashboarding tool, but could be creatively put together on a front page of an Excel spreadsheet if it needed to. This is a dashboard the council put together. Early in the COVID pandemic, we were receiving data from health centers and wanted to look at some of the demographic information that we were receiving based on the types of health centers. So if you're looking at 330H here, those are programs that serve people experiencing homelessness and have specific funding to do so. And so we were looking at some of the demographic changes over time and overall and across the different types of programs. We put this together with a tool called Infogram. There is a free version of Infogram. Obviously, you probably don't want to link directly to PHI, protected health information, but could be useful as a tool if you don't have something like that available. Wanted to, again, just provide a couple different resources for what this could look like and a few tutorials of how this could be put together. Excel, Google Sheets, and Infogram all have free versions, or if you're already paying for Microsoft Suites, you have access to Excel. Tableau often is a paid option. There are some limited features that are free, but is a very powerful data visualization tool that can get into like geographic mapping and things like that. Power BI is sometimes an add-on to Microsoft Suite, but can be really useful. And if you want to hit up Cassandra for that coffee date virtually to talk about it, I'm sure she could talk more about that. And if you're using any sort of electronic health record or case management software, there are often built-in tools that you can use to pull together some dashboarding and data visualization. We could talk about this for a long time, but I wanted to just highlight that we've got a few other resources linked in the slides that will be posted. So you can look at data demonstrating quality, medical respite, specific outcome measures, and potential recommendations for that. CDC's approaches to program evaluation, if you want to dig in a little bit more on the evaluation piece. If you want to dig in more on the evaluation piece, also let me know because I'm a huge nerd and would love to talk with you about that. Also just wanted to highlight a few different ways that you can facilitate the use of findings. These are, again, CDC resources where you can look at some examples of this on their website. So this got the screenshot of the website on here. But you can look at using your findings to co-develop recommendations and action steps. Look at creating actionable strategies for specific subgroups of your population, looking at how you provide multiple options for folks. Generating ideas and getting feedback throughout the process is really important. And then using this information to diagnose and contextualize specific feedback from folks. And then again, if you're thinking about how you are disseminating information, making sure that you're thinking about the utility of that information, the feasibility. So is it something that they can actually act upon? Making sure that the information is accurate, but also recognize that there might be some limitations with proprietary information and is considering who should have access to different levels of information. And as always, want to highlight the importance of thinking about how you engage stakeholders in this work. All right, at this point, I'm going to hand it back over to Craig to facilitate a conversation with Mariah and Ashley.
Thank you so much, Lauren. Similarly, thank you, Mariah and Ashley, for joining. If you don't mind, maybe we'll just go down the line and if you guys can introduce yourselves, maybe your name, your organization, and how you use data with your organization. Start with Mariah.
All right, thanks. I never want to interrupt Ashley. So my name is Mariah, and I'm the Director of Recuperative Care at Colorado Coalition for the Homeless. We partner with all of the hospital systems here in Colorado for our 70-bed recuperative care program that has a very heavy clinical emphasis and focus. And we use data for internal collecting, external collecting and reporting, and to inform quality care, best practice, and also kind of funding efforts as well.
And good afternoon. My name is Ashley Brand. I'm the System Director for Community Health Integration and Housing at Common Spirit Health. For those of you who are not familiar, we are one of the nation's largest nonprofit Catholic healthcare organizations, overseeing care in 24 states. And we have a strong focus in partnering with our local medical respite and recuperative care operators across our footprint. I use that interchangeably because in every state it's called different, something different. So for that, just from a context perspective, and just really excited to be part of this conversation.
Perfect. Thank you guys so much. And as Caitlin said, if there's any questions, please feel free to add them in the chat and we'll get to them if we have time left over. Okay, moving forward. So for the first question, please feel free to answer either one of you, whoever comes up first. Can you share an overview of the QI initiatives implemented by your program or examples of QI from programs you work with?
Yes, so a few of the quality improvement initiatives implemented by our program. We opened our new program in 2023. So a lot of what we kind of started building was a foundation of robust data collections. So we have an integrated referral form that folks fill out that gives us information for all of the referrals we get. And then we have internal tracking that tracks our census, what sort of visits and support people get during a stay. We also have an evaluation form, an effort that collects feedback from clients while they are here. I think the initiative started in the program actually as focuses on how they're feeling about results from a frontline level that we roll into a dashboard so that we can think about decision making and process improvement kind of throughout multiple layers. We also collect our feedback for hospitals, and a recent kind of effort that we've partnered with one of the larger hospital systems here in Colorado, Denver Health, is looking at rehospitalizations.
And from my perspective, so we do not operate any program specifically, but obviously we have close partnerships with many of the operators within our communities. I think one of the things from a quality improvement standpoint that we've seen beneficial, and I will say this is not happening across our footprint, but where we see it happening is case conferencing, is really our hospital frontline staff and discharge planners having regular, if it's weekly or monthly, oftentimes it's more regular cadence when it's a newer program, on, how referrals are coming, what kinds of referrals are being approved and what is not, and why. I think it really relieves some of the tension between what hospitals believe recuperative care and medical respite programs can serve and what they can serve. And it allows for those conversations based on a foundation of trust and unified strategic approaches and goals. And so I think that's one of the things that we really try to elevate as programs are developing those relationships, is the regular connection and talking about it, and even looking at opportunities for, hey, Joe's in our hospital, we think this is an appropriate referral, can we have a conversation to talk about how he's presenting the hospital, what are the resources. I want to say a quality improvement, but an opportunity for better transparency. We always try to get our hospital leaders and discharge planners to tour. And we've seen some programs where they do like a video, and because our discharge planners can't always get out because they're very busy, having the video to see the space helps to identify why maybe a patient isn't appropriate or is appropriate, and what kind of discharge planning should be considered as part of that process. And so those are some of the things that I think from a hospital standpoint that we partner with. We also, and I know we'll get to this a little bit later, we have worked on creating a consistent template across our footprint. As you can imagine, 24 states, over 150 hospitals, the way we evaluate looks very different in every single program. We are not fully implemented yet, but we've started small to create more of a consistent way to collect data, to be able to help our partners with the utilization, because we know that's really hard for community-centered programs to get hospital utilization if they don't have direct access to data. And so kind of figuring out what that looks like, but also making sure we're highlighting all the other services that happen in medical respite around income, getting connected to primary care, substance use, benefits. And I know I typed in it earlier, and I think one of the things that's going to really be important as we move forward in this work is how do we work together to ensure recertification is happening, because we know that that's going to be a big component. And again, it's going to look different in each state.
That's great. That feels like there's a lot of amazing work happening. With these initiatives that you guys have spoken about, were there any key factors that were the driving motivators? And if so, with the development of these initiatives, how do they affect the clients that you're working with, the partners that you're trying to meet with? I know, Ashley, you mentioned partnering a little bit, but if you could maybe go into that as well.
Yeah, I mean, I think from a hospital standpoint, and I've been with Common Spirit and Dignity Health, which is Common Spirit is a parent company, for 13 years, and I came from direct services prior to that. And I think one of the things we always talk about, and it's not new to anyone on this call, is healthcare and homeless speak very different languages, but yet we're trying to serve the same population and the same community members. And so oftentimes it's kind of sitting down and creating that foundational trust and shared vision so that there's a unified approach as we move the work forward. And I think that foundation does then help when we have these case conferencing or there's difference of opinions of what patients are appropriate and not. And it allows for us to have really hard conversations because, again, we're all trying to make sure that the patients have the right discharge care that they need. And so I think just having that partnership, having that regular cadence of communication, and not always coming together when it's something bad to talk about, but celebrating the wins helps to really, again, bring that partnership together. And for us collectively to recognize the more we work together, the more we collaborate, the more it's going to benefit our community members who are unhoused. And so I think that's an approach that we've seen be really beneficial for all parties that are trying to serve our unhoused community members.
We actually work with Common Spirit, and I've been lucky enough to know Ashley for years now on this steering committee. And I think when I think about good partnership and kind of motivation and alignment, they're a great example of that. And like Ashley mentioned, having folks in the care management or care coordination teams come see the space or see videos, and having more understanding around what your resource might look like helps them. I also remind my staff and the hospital staff and myself, and I think for all of us to really think about, we are all coming to work for the same reason every day for the most part, to help people. And are the main goal, right, with any hospital team that's working on discharge planning is the same as ours. We want that individual, that human being, to get to the best resource for them. And so I think really approaching this work as a partnership and thinking about data as a tool that helps fortify that is what we've been able to do in our new program. Ashley mentioning that tour, a few years ago, we looked at data. We were seeing a lot of what I'm going to call referrals that our program probably wasn't the best resource for. And so we kind of, because we track all of our referrals, right? Do they come to the program? Do they cancel? Do they get denied from our registered nurses that are going through the referrals? And we really dug into the denial reasons. And we did see that one of the main reasons was folks that can't safely navigate their ADLs or safely navigate around the space we had available. And so we partnered, we found a PT in the community that has a really big heart for the unhoused community. And she actually came and partnered with us looking at that data to be able to go through and help write out what kind of stipulations a referral would need to meet to be safe in the program. And so, that's kind of an example, I think, of understanding, in good faith and best faith negotiation that we are all just trying to get that human being taken care of, and then using data to inform what we actually do with programming wise and partnership wise. And then we were able to kind of give that package to the hospitals so that their care teams could look at, someone has to be able to ambulate 100 feet safely. That's a lot more helpful for the hospital care team and their PT team and nursing team to know than my nurse to just say, oh, well, someone has to be able to go to the bathroom, without assistance. Kind of marrying the two languages between the resources is something I think that data helps us figure out. It kind of helps us figure out the roadmap for these goals that we collectively have.
Yeah, it sounds like it's very helpful. Like first, it's thinking about the client and finding those partnerships, and then using the quality improvement to achieve your goals. That's the first step is those partnerships and working to help the client as best as you can.
Yep. Great. Can I just add one thing about some of the opportunities that we're seeing? Because I think Mariah touched on a few. One, oftentimes we know home health, occupational health, those that should be able to come into a medical respite program have some challenges or have some preconceived notions. And so I think some of the quality improvements, to Mariah's point, is as we're seeing the complexity and the acuity level of our patients go up, how do, as the health systems and the operators come together to bring in these partners and help them and educate them on what programs are, why it's an important opportunity, and why these individuals, just like they're going to their home, should receive the same care. And I think those are opportunities for quality improvement as well. The other thing, and this is happening in small areas, and I know Caitlin's on the call, and her and some of my colleagues at Common Spirit are working to elevate this, is the recognition, again, with the acuity level. How do we partner better with SNFs, skilled nursing facilities? And so medical respite becomes a step down because, again, they're not appropriate for medical respite in those immediately discharged. But if they can spend a week or two in SNFs and then be discharged as a secondary disposition, that allows for us to support the fuller journey of the individual while recognizing what's most appropriate at the time. And I think those kinds of quality improvements, to Mariah's point, if we're seeing a lot of data around people that are too high of acuity to go to medical respite, how do we partner with others that become part of that enhanced continuum of care?
That's perfect. Thank you guys so much. Okay, moving forward with the next questions, Lauren. Okay, perfect. How do your programs you work with use data to identify where improvements are most needed?
I'll start this. I will say from the hospital standpoint, I think there's two components that we look at. and Mariah already touched on it. If we can see that many people are being denied because there's not bed availability, and we can look at our hospital data to show, how many people potentially could leverage it, that's an opportunity to look at how do we bring capacity building dollars to increase beds. That's a kind of a simple data collection. Oftentimes we haven't been in the past collecting the people that were denied. And the reason why, and I know Mariah just touched on that a little bit, but I think that's data that is compelling when we, bring it to larger communities. And this is not something, for one hospital to own, but collectively we're seeing, hey, there's a need because most people are being denied because beds aren't available and people are needing to stay longer. I think the other thing that we are trying to articulate is historically there have been more housing solutions post medical respite. And I think what we're really trying to identify now is medical respite is not a permanent housing step down. It's people cannot go in from medical respite for 30 days and then expect to be permanently housed. And I think, so it's level setting expectations. But one of the things that we're really trying to highlight is what happens when they're in medical respite, because our leaders in our hospital don't always see that piece of it. So how do we make sure that they understand the services they're getting connected to that they otherwise would not if they were going back to the streets? And so trying to make sure we're painting the picture of both the hospital utilization piece that we can look at, as well as what's happening within the partners while they're at their stay.
Yeah, I think when we think about kind of strategies, really thinking about data collection, like Ashley said, I think it's always nice to know where you are, like what are you looking at? What's your program doing? And then I think looking at ideal state of what we could be doing. And then to me, the data and kind of the focus on that helps inform us where we need to go, I guess, right? Like it points us in a direction of where we can move forward. And then I think it does provide some level setting. I do think a lot of folks, regardless of how often we say how hard housing is to access in recuperative care in Colorado, for example, it's, if you qualify for affordable housing, it's a 2-year wait, basically. So, being able to have some data and numbers to keep informing those conversations and guide advocacy and policy when we are talking to legislators. And CCH is really fortunate that we have our own kind of advocacy team. But a lot of times I think people think about the world that they want to live in and how they think it should be. And then data helps us really paint a picture of what is. And then again, guides us to kind of get to where we should go and what we should focus on. When we see issues with denials or we're talking to funders, if it's a hospital or a foundation or the city and county, we're able to kind of look at numbers to help us prioritize what we need to focus on next. I also think that collecting data around staff, how they're feeling in the program, the kind of things that they want to see and that they care about. One of my peers or case managers might feel very differently about what we need to track than one of our providers, our primary care providers. But it does give us an idea of what we all collectively define success as. And I think that that's another way that we kind of use strategy to use the numbers that we collect to see how we're doing. And then, safety. I'm a registered nurse and our program has a very heavy clinical element to it. We have 24/7 clinical staffing. So I'm always thinking about safety, literal safety, but also psychological safety of our clients and staff. And we track metrics concerning safety a lot to look at to kind of guide priorities. Do we need more staffing somewhere? Do we need to rethink about the shifts we're scheduling? Are there gaps that we're seeing in care? And we're kind of able to shift bandwidth to priorities that are established when we're looking at data and we see gaps as well.
You kind of mentioned this a little bit, Mariah, and actually, if you want to jump off as well, but strategies for prioritizing issues. Mariah, you mentioned funding or speaking with staff about what they've been seeing. But do you guys have any other strategies or ways that you prioritize what needs to be addressed? Because we all know there's a lot of issues that need to be addressed. So how do you figure out that first step?
I'll go because I think I want to set Ashley up for something as a trusted hospital partner of ours. I like to remind staff that hospitals and funding entities don't sit around and just decide to track something to make anyone at recuperative care miserable. I promise you, they're not paying someone to do that. And so if we think about data, it's really a snapshot and a metric that establishes what we're doing and what we should be doing and what we could be doing and what we're not doing. And so I like to remind myself and my staff that you know, if a funder's asking for something, there's a good reason for it. And then it's usually my job to try to translate the why. But they're not asking for it because they didn't have anything else to insert in the RFP. They're asking for it because it guides their decision making with all these resources, right, that are right now in finite, that we're trying to all work with. So yeah, funding does guide some of our strategy and prioritization, but it guides it because there's a reason that something is getting funded and that a funder's requesting we collect something. And then again, the safety component, we really prioritize safety metrics as well. And then kind of just I'd say program effectiveness to clients. If at the end of the day, if most of our folks don't think we are offering a service that they find useful, then we need to pivot and change our services around.
And I think for us, and thanks, Mariah, we are very cognizant that many of our operators are being asked to report different things for all their different funders. And it's really hard. And we're trying to find that balance between how do we create across Common Spirit a consistent way for us to evaluate programs and then leverage the data to see what are the themes, because for us, it's probably not going to be a one-by-one program, to be completely transparent. I think oftentimes we're trying to see what are the themes that we're seeing across our footprint, and then how can we help? How can we work with NIMARC to find, where are these kind of themes that we can then scale and replicate solutions for across our footprint? So we have been working on creating a spreadsheet that we are asking our operators to complete. We use the data to look at utilization around readmissions, length of stay, but it's also telling the story of what's happening to the patient while they're in medical respite. And then our goal, and this is still a work in progress, is to create that dashboard then to see where are we seeing successes, what are those opportunities that we can then through a learning collaborative teach others from one operator to the next. So I will say for us, it's a little bit more large scale than program specific. But even the data at a program level does help our discharge planners work more closely with the operators, increase transparency and education.
Fantastic. Thank you guys. And someone asked a question. If you guys can answer this, that'd be great. But if not, we can answer on our end. But Marissa's asking, our hospital partner wants to see certain data. Our org wants us to track data related to MCO billing, and we want to make sure we're hitting NIMARC standards. We end up seeing how increased requests for data cost money across the board. It seems like they're getting pulled in multiple directions. Do you have any advice on maybe steps that they could take or advice on that?
I mean, I think so. It was interesting. We were working in one state when they were starting the billing. We asked the payers, what are you guys going to collect so how we can work together? And the payers were like, we don't know yet. So we started creating something. And we told them, hey, if you guys ever want to partner, I think I don't have an exact solution, and it really depends on who your hospital is that you're partnering with, who the MCO is. But maybe an opportunity to pull them together and saying, hey, this is the data we're collecting for you. This is the data. Are there any shared templates that can allow us at least to report, even if we're over reporting for one, or, there's not interest, but creating a shared template so that at least they're not duplicating data collection and that sort of thing. That would be one approach that I think, again, I can't guarantee how it's going to be received, but that there might be ways to think about that. And Marissa, I'm not sure where you are, but happy to, throw things at the wall with you to see what might stick. Because I think we're all playing this balancing game together.
Perfect. Thank you so much, Ashley. I hope that helped Marissa. And if I know Ashley offered, but as well, if you want to reach out to our team as well to talk it through, we're happy to help. Could I get the next slide, Lauren? Perfect. Okay. Could you guys describe a time when program data directly influenced your program's implemented changes?
I'll leave this one to you.
Yeah, again, I just kind of overhauled this staff survey on resilience, and we just implemented a new change where we're allowing folks to choose if they have to pick one or the other, but if they want to do 3 12s or 4 10s. I figured it out operationally, I figured it out budget wise, because we were getting a lot of feedback on just resilience and how hard life is. And so that's something recent. Another kind of maybe client care or program related one is we track our discharge locations, and over the summer in Colorado, it's very nice outside. And so a lot of folks were leaving before they were kind of meeting their expected length of stay planning. And so we actually came up with a new pass system to kind of meet the needs of clients, to be able to better track and kind of better allow for them to leave the program and come back with our access control. So those are 2 examples. I will also say to Marissa, I'm a pretty big data nerd. So when I got into this industry, we do have a very robust collection, single sort of from funders. And I will say that something that has been beneficial of us kind of robustly collecting everything is it does give us flexibility when we're doing grant writing to write in outcomes that might even influence their next round of funding or influence the next RFP or be a discriminator for our program against another program that might not be collecting that or be thinking about data from a lagging perspective. So that is something that has helped us a few times. I'm thinking about a lot of the food as medicine grants. We were already kind of tracking things related to food and some outcomes anyway, and it helped give us a leg up probably over competition in the community for grant writing because we had more robust information to share that the grant wasn't necessarily directly asking for, but that we could kind of marry indirectly. And then we created a position that manages kind of patient flow and intakes and discharges, and also kind of the lower level data collection. And so we didn't add any new FTE. We just kind of reshaped 1.0 FTE to kind of manage that. So there are sometimes you can kind of piece together different lanes of bandwidth you have and reintegrate or redevelop a position as well. We try to do that a lot.
And
and I'll say just from a leadership perspective, the work we do, right, the end users of whatever you're doing are going to know better than anyone else. So they're going to know way better than someone in an executive office suite. And so we always try to incorporate client feedback into everything, even when we don't want to hear it, even when it's hard to hear, even when it's going to be something we've worked really hard on, and it's going to hurt our feelings a little bit. That's okay. Uh, Being able to provide services that are effective at the end of the day is everyone's goal. And so I would just say definitely get feedback from the most end user of something. If it's you're getting staff feedback, like go to your most frontline, hardest working staff, and those are going to be your case managers and your MAs and your nurses and your cooks and your housekeepers. Try to get the most direct frontline view of something you can get, because that's going to be what actually shapes things. When I'm talking to hospitals about partnerships, I'm really lucky. Again, I get to work with Ashley. I get to work with a lot of directors and VPs, but I also call the frontline social workers, that are the ones making the referrals in the hospitals about what problems they're seeing. Because then I'm going to get more details that's more granular, and that really helps keep things in the right perspective.
That's perfect. That actually jumps into the next question of involving staff and clients. Ashley, I don't know if you want to build on that as well. If you have experience working with clients, is it more just getting their like what they're struggling with, their opinions, and then moving forward, or like are there ways that you're directly involving them with the work?
I want to say from the hospital that it's patient specific. We have what we call research and equity advisory council on housing insecurities, which is a lived expertise council that guides us in how we invest and how we partner across Common Spirit. We've had them for about 2 or 3 years, and one of my colleagues leads them. So that's where we get really the most perspective. We're actually working on an evaluation for medical respite and recuperative care. We're identifying 5 sites across our footprint, and we will have an advisory board, which will include those with lived expertise and those who were either current or previous patients of medical respite and recuperative care. So I think we're trying to figure out what that engagement looks like. I don't know from a patient perspective in terms of referral. I think it's more on us educating them on the resources that they could access and making sure that our frontline staff is really well educated on what it looks like, the environment, so they can address any concerns that a patient may have about being discharged to somewhere that they're not familiar with. So that's one piece. I just want to flip back to the first question really quickly. I love it. I think one of the other things from a data perspective, we look at utilization, and I think there is a recognition that this patient population is getting older and unfortunately getting sicker. And so from a hospital and health system perspective, I've really tried to focus on key metrics that still help address throughput, like length of stay, but also being very realistic on recidivism and readmission rates, because the individuals are sick and they do have to come back to the hospital. And so making sure there's clear communication on what data elements influence our understanding of the realistic elements that we can address. So I want to flip that, because I think it's really important that when we are having conversations with partners, we're honest and we level set of what this program can do and what it can't. And yes, there's going to be great success stories, so I don't ever want to minimize that, but it's also the hospital is the one place that they can come back to 24/7. And that's what the medical respite providers count on for them to be able to access that in emergency services.
Perfect. Thank you guys so much. Almost at the end, but if we could jump to the last questions. What specific types of data have been most helpful in driving program improvements? Any tools or practices that you guys have found useful?
Mariah, I'll let you.
I mean, we try. To me, we track a lot. We track a lot of things. I think the things that have been most helpful in driving program improvements are, again, thinking about who are our customers. It's our clients and the hospitals and funding in our community, and thinking about what we need to track to know whether we're being successful or where we have improvements and gaps in. So we track all of the demographic data. That's actually led to some really interesting conversations with the hospital because we have data around what homelessness looks like in Denver. So if I see data for referrals that actually doesn't reflect that, I called up case managers and I'm like, hey, this is interesting to me. We're not seeing as much diversity and the referrals we're getting. What can we partner with in the community, or what do we need to think about? So I think things like length of stay, discharge from our program, we track the kind of care and support they get in the program. We do client satisfaction surveys, but really we think about it as more of just guiding the care that we're providing. So it's not, did someone, like their stay, but it's like, was the as clean as you would hope for, and we kind of look at different pieces of the feedback that we get and try to, again, plan staffing around that, or bandwidth, or think about gaps or what might be causing safety issues. If we're seeing a rise in safety issues, I start looking at a lot of things to try to piece together, what might be going on in the program. And I think also just thinking about rehospitalizations, and that's the thing that I think our community and funders care about a lot. So that helps drive improvements in the program. If hospitals don't have beds to discharge to, it also needs to inform the community that, right, there are more resources needed. So I'd say demographics for sure. So you can make sure you're serving the population in a diverse and equitable manner. If there's clinical care involved, are there clinical outcomes that you're seeing that you want to see? And then satisfaction from clients is important. If no one wants to come to any of our programs, we're not going to be doing what we need to do every day. So those are kind of the three main ones. Others might find useful. We do a lot of dashboards. People like pictures. People like pictures, and marry it with a story. Marry it with a story that was impactful. My staff cares about people and stories, and I care about numbers and spreadsheets and pictures. And so, you need both, and try to just marry both of those together.
That's perfect. Thank you so much, Mariah.
Yeah.
A couple more minutes. I don't know if you guys want to end with, if there's anything that there's missing in the conversation, or any final thoughts you'd like to add before we end the panel.
I mean, I think one of the things that Marissa brought up is I totally understand that there's been a lot of requests in different data. I know we have conversations at NIMARC all the time, is like, what are those consistent key metrics that we all feel like, that's a conversation that's happening, but I think it's such a critical conversation that we continue to elevate, because everyone is tracking it different. Everyone is looking at their program differently. And so really trying to figure out what are those key elements that we can really lift up. And then that becomes part of the contracts, that becomes, it becomes part of the culture. And I think Marissa mentioned earlier, some admin folks keep asking for more. And I think part of it's like, here's what we agreed in the, contract of the data that we can provide. If there's additional requests, like, what does that look like? Because I know the request is coming from a good place, like Mariah said, but how do we kind of put that in the contract so there's a level set of expectations of data that we're collecting? I think, when we talk about quality, I think it's also important to, and I know I've already said this, but like what respite is and what it's not. So when we talk about quality, there's an understanding and a baseline of knowledge to say, this is what we are experts in, this is what we're not. Because I think when we don't have that clear set of expectations, what we define as quality is not always the same. And so I think, some of those components are really important to continue to have, just as medical respite hospital staff changes, and we change quickly, and we have a lot of travelers. If you guys are not familiar with travelers, they come and go for 3 or 4 months to different hospitals. So they don't have the knowledge, they don't have the education and awareness all the time. And so some of these key components, I think, help create that foundation and culture. So regardless of who's referring, regardless who's looking at the quality and the programmatic piece of it, it creates more of a consistency as we move forward.
Fantastic. Thank you guys so much. This was incredibly helpful and information. I'm sure everyone benefited. Really appreciate you guys taking the time to just share your expertise. Lauren, I'll leave it to you.
Thank you again. Amazing conversation. We're gonna have another quick break. And then when we come back, we're gonna spend a few minutes chatting with each other, and then we'll have some opportunities to hear from the in-between before we wrap up. We're gonna have 3 more breakout topic conversations. One, we'll start providing some resources and talking a little bit about what it looks like to draft QI workflows. Start thinking about how you start deciding what goes onto a dashboard, and then thinking about dissemination of findings. So if you just take a couple minutes to pop in what you're interested in, and we will come back at 5 after. So we'll be about a 10-minute break. Thank you all. See you in 10. Welcome back, folks. Thanks so much for participating in these discussions. We wanted to bring it back to this group again just to see if there was anything that stuck out or any additional questions for this group before we moved into the next section of our agenda today.
Hey, Lauren, there was a participant in my group that was getting ready to ask a question at the end, and I just wanted to open it up to see if they are comfortable sharing in this group space because I did not want it to go unanswered. And I will also say you can email me if you would prefer to do that.
Thanks, Sarah.
Thank you, Samantha. That was me. I wanted to follow up with Lori. She was mentioning sort of developing foundational outcome for her program. So I wanted to see if you could share maybe some of those outcomes, particularly the ones related to post-medical respite.
So when we were developing our foundation, what I was telling our group was that when I first started with the Center for Respite Care here in Cincinnati, we had all kinds of outcomes all over the place because if a grantor said they wanted to see XYZ, we were just starting to track XYZ somehow. And so we had way too many, way all over the place, and it was a nightmare to track. So I pulled staff in and I said, what's most important? Let's figure out how we can determine what's most important to us as a medical respite, and then maybe what's most important to the community. So that would have been second. And like looking at things like community benefit plan and what our community, and almost every one of them from the systems indicated like COPD and lung issues because the air is bad here. That was a big community concern. So I'm like, okay, well, can we track something like that? So we started with some foundational, like the one example I gave to Bobby, who was in our group, was there's got to be somewhere that a person is going to go after medical respite. Medical respite is a short term. There's going to be something. So we created common goals for our individualized case plans and its placement, medical home, like the things that every single client is going to have an expectation of completing while they're there. And then tracking those types of things. Now, some of that leans more towards demographic, but it was also, if you came in with diabetes, let's take an A1C and let's take it on a regular basis, track it, and then report on it at discharge, like what was the improvement. So we did some basic health outcomes based on what happens in our community, and it's going to be a little bit different. We have lots of diabetes, we have lots of COPD, lots of kidney disease. So those were easy ones to track, not common for everyone, but placement's common, medical home is common, connection to community support is a common. So those are all ones that we pre-populate. I should say we put them in. I want them to be more pre-populated through our HMIS, but right now we're just typing those in to say that's what we would track. And, okay, yeah, hey, University Hospital, who's one of our biggest referral sources, we track where somebody establishes a medical home, and here's the stats on that. 90% agreed to establish a medical home and had at least one or two visits before they were discharged from our program. So something like that. And then what we had was this foundation of outcomes that we could go to grantors when we were like discussing a grant or funding from like some of these entities and saying, hey, look at all these things we track based on this information. What sounds good that we could put in this grant, or what would you like to see out of these? We kind of flipped the script so that they weren't telling us what to track. We were telling them what we were tracking. And in most cases, it works. I still have those people that are like, well, what happens to your clients 2 years after? And I'm like, I don't know. We try to find out, but we don't, that doesn't always work. But that's kind of what I was talking about. So is that clear, or more questions about that? I'm happy to answer. I don't want to take the time though.
No, that's helpful. Thank you.
Thank you both. Any other reflections, comments before we move into the next section? All right. Okay, great. So we are very excited to have Jillian Olmsted take some time to share the work that they're doing at the in-between. So Jillian, I'll just hand it over to you.
Okay, thank you, Lauren. I'm going to share a presentation. Hopefully I do a better job than I did a couple of days ago with you guys on it, but I think I learned what I was doing. Okay, is that still, okay, great. I couldn't get it to let me go on to presenter view 2 days ago. So thank you for having me. My name's Jillian. I'm the executive director here at the In-Between, and I'm excited to share some really practical things we've been doing with data here and helping people really start where they are. It can be really complicated when you think about collecting data. And if you look at it as we got to do it all at once, it's probably going to be really difficult to ever get started. But a brief overview about the In-Between. So we're a medical respite and end-of-life care facility here in Salt Lake. Right now we have 80 beds. We recently expanded. And we serve people who are terminally ill, medically fragile, those who are recovering from illness or surgery, and a lot of folks that are cycling repeatedly through hospitals. Our outcomes are deeply human, but we also track utilization and system level impact because that's what those decision makers are asking us for. And I liked what Lori just mentioned. As much as possible, if you can tell people what data you're going to collect versus them telling you, do that. Sometimes pushing back can make everybody's lives easier. So if it doesn't make sense to really prove your story, maybe see if that funder or decision maker really needs that information. So these are 4 areas of data that we collect, and I'll go over how we collect it. So first is our operational and utilization data. So we're tracking our referrals, how many of those referrals turn into admissions, how many bed nights, length of stay, emergency department visits, primarily before they come into our program, so we can see how much that was reduced. hospital admissions, and then hospital readmissions. The next area of data is our client outcomes. And these are housing outcomes at discharge. As someone previously mentioned, it's really hard to follow people. So we don't do that. We track where they go, and that's really where it stops. Medical stabilization, recovery off of hospice, since we do have many people coming in here on hospice and just having that access to professional medical care and a roof over their head, they rebound quite a bit. And then we track how many of the barriers and challenges to housing that have been reduced during their stay here. We have qualitative and experience data. So this can be resident narratives, if someone gives us their story, resident satisfaction, which is a part of our care completion assessment. So we're asking them how they felt their time was here. Did they receive the services they were needing to receive? And do they feel that they have improved health-wise? And program assessment data. So we complete a needs assessment at admission and again at discharge. And this will help us identify both individual progress and our program level strengths and weaknesses. Important to note is that this really doesn't have to be fancy. So while we do have an electronic health record system, it's not required. So I'll talk a little bit about how we've transitioned most of our data collection into our electronic health record system to make things easier so that we're not recording data in so many different places. And we can reduce using tools like a Microsoft form or a Google form, spreadsheets, things like that. One of the biggest changes we just made is previously we were doing our needs assessment via a Microsoft form. So it was kind of survey style. And we had to have two separate assessments so that we could compare when they came in and when they left. Now this is in our electronic health record system. And the coolest part about that transition is that it then just turns into a care plan, or what we call a medical respite goal plan. So if we're asking them if they need help with their driver's license and they say yes, on the next page, it turns into a form where we can fill in what the next steps we can help provide for getting that identification, what they need to do, and any sort of external supports. So it has saved us a lot of time, paper, and again, just reducing the places that we're entering data. As far as the staff who help us collect data, the majority is with our medical respite care coordinators, similar to homeless case managers and other organizations. And then we've also hired a program support coordinator to help with any of the duplicate areas that we're tracking data. So we also have that homeless management information system here in Utah. And since we do get some city and county funding, we're required to enter demographic data, where they discharge to, their financial status and things like that. So if it's not helping care coordination give better care to our residents, we're trying not to put more of that data collection burden on them. And our resident satisfaction data is gathered during that care completion needs assessment. And then we've also collected utilization data through our hospital partners when available. Since we do have access to a hospital-wide electronic health record system, that allows us to check some of that information that we wouldn't normally have access to. Successes we've seen. So one of the biggest successes we found was shifting how we compared outcomes. Instead of comparing our residents to the general population and their healthcare needs or utilization, we compared our referred and admitted individuals to referred but not admitted individuals. So those could be individuals who didn't meet criteria. Maybe they went to a higher level of care. Perhaps they left whatever setting they were in before the referral could be completed. And we studied this data for over a year with the help of a Morgan Stanley fellowship program, which provided us with an individual who was also studying for her social work degree, which was a great fit. And she focused on this project for a little over 10 months. And it helped us immensely. It allowed us to show reductions in emergency department utilization, hospital readmissions, reduction of length of stay. So we were comparing apples to apples, which really did lead to actual dollars and cents savings. So this one pager here that has the graphics on it. We took that study and turned it into a really simple one pager that we could use during the legislative session. As probably most of you know, it's really great to tailor your data to whoever you're speaking to. And when we're speaking to the legislature, we want to tell them how much money we're saving. And then as the secondary part, how we're helping human beings get better medical care, because they care a lot about emergency service reduction as well as cost savings. We believe that this study helped us with our appropriation, which was a $450,000 one-time amount to help us with our expansion and $100,000 ongoing. And in Utah, it's extremely hard to get ongoing funding through the legislature. So since we were able to do that, we felt like this was a really great win. And then the individual who did this study for us, she also published a literature review, which there's an image of it here on the left. Both of these should be available on our website. If anybody's not able to find them, I'll have my email address at the end and I can share it. But being able to have these independent studies is really great because, of course, if you're collecting your data and you're telling the narrative, we are probably all telling an accurate story and painting an accurate picture. Really, really great when we can say a third party came in and did something for us. Lessons learned. We've had plenty of challenges in our data collection, and I would say we just turned 10 in August, and it probably took us 7 years to feel like we really understood what we needed to collect, how we needed to collect it, and how to be firm with our funders on what we would or wouldn't collect. So I think it's important to know that small sample sizes are real. It's okay if you can't do this gigantic study or if you don't serve a ton of residents. Accessing cost data, not charges, is really hard. We had difficulty with any sort of insurance companies or Medicaid telling us the true reimbursement rate for things. So we actually worked with the Kaiser Foundation to get some of those general costs. So I think it's important to start where you are and know that even if you're just going to be collecting housing nights, number of individuals served, and maybe some really basic health data, that's going to tell a really great story. And also don't wait for a perfect system. So while I highly recommend an electronic health record system because it's going to do a lot of work for you, not only for your day-to-day medical respite delivery, but also being able to pull a lot of reports and being able to paint a good picture. Know that we were operating in a spreadsheet up until about 3 years ago. And pre and post admission data is incredibly powerful. I've heard this mentioned here today, that just being able to even have that self-reported data that these issues were happening before and they're no longer happening now. And whether that's just follow-up appointment attendance, being able to get their medications filled, all of those small things will help with your story. And then I found a lot of support with other respite facilities or hospice facilities. So lean on the directory with the National Healthcare for Homeless Council to find other organizations that might be similar to you that may have already led this charge and gone through a lot of the woes so that they can tell you about it and you don't have to repeat all of those lessons learned that some of us have. And data should always support your mission, not overwhelm it. It's a very delicate balance because you might not be at the point where you can hire someone to specifically do data, and maybe you don't have anyone in your organization that data is second nature to. For me, it's really difficult for me to think about changing how we track data or changing some of the metrics. It seems too big for me, so I always lean on other people that it's more second nature to them. As far as quality improvement, so we're not just collecting data, we review it and use it and make sure we apply it to what we're doing. So our data is formally reviewed during our quality assurance meetings. We usually do these quarterly, sometimes more often if something's going on or if there's changes. And this includes our medical team, so our RN, our care coordinators, our assisted living administrator, who's also our dietitian. And then again, depending on what we're talking about, we might bring in other staff members like our facilities team or our volunteer coordinator or our resident advocates who are lived experience experts. And we want to make sure we're looking at trends versus any one-off thing because those happen all the time. So try to focus on the trends. And for us, that's a lot of utilization, length of stay, discharge outcomes, and of course, resident satisfaction. This data helps inform our future staffing decisions if we need to modify our intake criteria, which we're doing right now. How is our referral process going and how are we doing at discharge planning? The needs assessment at admission and discharge are really helpful in identifying any systemic gaps and not just individual challenges. And then we also include information from our resident council. So this is a resident council is actually required if you have an assisted living licensed facility in Utah, which we have. So it was really great because I don't know if we would have started it as soon as we did. But the residents get to vote people in to be president, vice president, secretary, and they're meeting weekly and they have a form that they use that just guides them through different discussion points to try and suss out if they feel like things could change in our program. And this could be as simple as more coffee pods, which is often the case, to more variety in the food we're serving. Or one that I felt was the most impactful was we had a couple of people talking about the way that we describe care completion or discharge. So we really try and use care completion versus discharge date. And we make sure that it's talked about before they get into the building. And anytime we're having our one-on-one meetings with our residents so that they just really know this is your care completion date. Here's what we're working on up until that date. We don't ever want it to be a surprise for them or cause any panic. As we all know, most people who go through medical respite, it is short term. They are likely going back out into the shelter system if we haven't been able to find an alternative. Looking for the most important impact and what tells the best story. So data can change things internally for you and externally. So a couple of examples for us was really looking through our utilization data help strengthen our hospital partnerships to advocate for sustainable funding. We actually don't have any ongoing funding from our hospitals here, but being able to show these better outcomes and lower costs over the last couple of years did lead to a one-time contribution, and they seem to be just better partners with us. So I think we all know what we're doing. And we're all, especially the boots on the ground individuals, are working very hard to get people into the in-between or medical respite program. But you have to get in front of some of the people higher up the chain so that when they're talking about where they might have their funding go to, it's going to some of these nonprofits that are making a big difference in their patient care. Our length of stay data demonstrated value to our financial stakeholders. So think your funders that are through grants and foundations, and it helps support our conversations about Medicaid and value-based care. So Utah recently is now allowing us to bill the medical respite waiver. It passed over 5 years ago, so it's taken a long time to get to this point. But we worked really closely with the Center for Medicare and Medicaid Services to ask them to please push this through so that we can start the pilot program. And again, showing them that anytime someone stays here compared to if they don't come in, it's a $47,000 cost savings to stakeholders just right off the bat. And one of those stakeholders is going to be the government and insurance companies. Our resident satisfaction data led us to those improvements in communication that I talked about, discharge planning. And for us, really the most important data is a combination of all of these things. We want to make sure that we're not just focusing on these static numbers, that we're bringing in those stories from our residents, because what happens to them and how they feel about their stay is just as important as that $47,000 cost savings to anyone in the community. And know that you don't need to collect everything, and you probably shouldn't. Residents being questioned to death is not going to be helpful for anyone in your program, and you might find that it causes the people you serve to lose trust in you. And then everything you collect, you want to make sure that you're utilizing, so don't collect data that's just sitting there. So just key takeaways from what we've learned. Make sure that you're using data for improvements and not just reporting. A lot of our funders actually ask us now, it's a newer thing we've seen on some of our applications, is what are you doing for improvements with the data that you're collecting? Know that you don't need anything fancy to start building meaningful outcomes. Start small and with the most impactful data that will tell your story. Build review into your routine, and don't just wait until your funding cycle when you're pulling all these numbers for maybe your annual report and things don't look too hot, and maybe you should have shifted how you were collecting the data. And I think most importantly, what I've learned is if us as medical respite programs don't tell our own data story, someone else will, and they will probably get it wrong. And I'm happy to answer any questions that anyone has. I have our email address here, which is info@tibhospice.org. If you have any questions or want to connect to go over anything, I'd be happy to. Also, the person who did that study for us, she's also really great about meeting with individuals about the 10-month study that she did. And on our website, which is tibhospice.org, we have a FAQ portion, which includes a lot of this information and some connecting links to the National Healthcare for Homeless documents, and our annual reports would probably be a great place for you to see how we've been utilizing the data that we collect over the years.
Thank you so much, Jillian. That was amazing. I've got some quotes written down. I loved the idea of data should support the mission and not overwhelm it. I also really appreciate the point about not over collecting data, and if we're going to ask questions, why and how are we going to use that information? I think that's always an important reminder. Any questions? We've got a lot of thank yous in the chat as well. But any questions?
We're happy to share. As I mentioned, if we're going to go through these struggles, we should at least share it.
Solidarity. Great. Well, thank you again, Jillian. It was incredibly helpful overview of what I'm sure is a lot more work than it sounded.
Of course.
So,
thank you for having me.
Yeah, appreciate it. Okay, we have just a few more minutes left, and wanted to do our own quick overview of some key takeaways. If you forget everything that has been said today, here's a couple things that we want you to remember, and then we wanted to get a little bit of feedback from folks in the room as well. So we hope you'll stick it out for another 10 minutes with us. If you forget everything that I said, hopefully you won't forget anything your peers said. But if you forget everything that I said except for these things, just remember that quality improvement and evaluation are different but complementary processes, and that both are very important, but start with which one makes sense for you. Try to incorporate quality improvement into your program planning. It's a lot easier if you start thinking about where it fits into your existing workflows earlier than later, but anytime you start is the time to do it. We encourage you to think through how you can collect a range of different outcomes. You can think through different health, social, or programmatic outcomes. Start with the tools in the community that you have. Again, doesn't have to be perfect, but start somewhere. We encourage you to consider how you're going to center folks with lived experience. How are you going to bring in patients, clients into this space and use their feedback for quality improvement work? And then make sure you share your findings. As Jillian just said, if we don't talk about the outcomes of our programs, someone else will, and they will get it wrong. So highly encourage you to think through how you will share the work that you're doing and use the data that you have to support it. I would like to hear from you. And so dropped the QR code up here for Mentimeter. Let me grab the link for that as well. Mhm. While you're doing that, I'll answer Marissa's question in the chat. Yes, we're going to plug this again in a minute, but there's actually going to be an evaluation learning lab at the beginning of the conference, which is like a 4-hour interactive deep dive around evaluation concepts. And so we are definitely, well, you can really spend a lot of time in the same room together physically with each other, which will be really great. And then there are also some sessions on data evaluation and a couple sessions from programs that go more into depth around what they're doing at conference. So yes and yes. Yes, and we would love to share the same physical space as you. All right. Next slide here. Okay. You can still use the link in the chat or this code at the top, but I love a good word cloud and I want to hear from you. And so I just would love to hear what you're going to be taking away from today. Not taking anything away. Purpose. Love that. Data supports the mission. Yes. That's what I'm taking away from today, for sure. It's okay to start small. We encourage it, in fact. It can get overwhelming. And when you're starting small, celebrate. Celebrate all the steps along the way. Every step is a big one. Reducing redundancy. Partnership. Knowing your goal. Be focused outcomes. Thank you all for indulging me in a word cloud. I appreciate it. We love data visualization in real time. Yeah. You're all encouraged to use tools like Mentimeter when you're getting feedback. Does the visualization part for you. Importance of stories and partnership and data for generating support. Love it. Lived experience. Data for stakeholders. Awesome. Well, great. Thank you all again so much. Caitlin is going to launch a more formal evaluation poll so we can get data in multiple ways. And while we're doing that, just wanted to highlight the upcoming conference, as Marissa asked about in the chat. You can register. If you register before Saturday, there is a 15% discount. But we would love to see you all in Orlando, aka both Caitlin and my hometown. So would welcome you to join. There's a PCI, Pre-Conference Institute, full day on medical respite, if I am remembering correctly, and a half day, 4-hour session specifically on evaluation where we dig in a little bit more on the evaluation side of things and work with you to start developing some of those resources and do some evaluation planning. Again, huge nerd, would love to talk to you about evaluation for 4 hours. So if that sounds at all interesting, we would love to have you. Also, if you are interested in being part of the council's work, our call for nominations are open. This is for awards at our conference, being part of our networks, so Respite Care Providers Network being a very relevant one, and joining our board of directors. All of these things are open through the end of February, and we would love to have you in any and all of our spaces. And that is what I have for you all today. Thank you so much for sticking out 4 hours on data with me today. I very much appreciate this time with all of you, and hope that it is the first of many times chatting with you all about data. I'll put my email in the chat. You're always welcome to reach out to me, the Respite team, Joey, Craig. We are happy to talk with you about anything.
If you can find one of us, we will connect you with the person who knows the answer to what you need. So yes, please do reach out.